Hi, my name is Lee Lehan, metric number 066275. Today I will present Case Report 2, the clinical case of heart failure and ischemic heart disease. So this is an 83-year-old man with moderate COPD, family history CAD, past medical history, arterial hypertension and diabetes, and also social history of smoking since childhood. Let's review the case. So in February 2009, the patient experienced 2 weeks of angina and also suffered acute AMI. And these symptoms occurs more than 12 hours. And so this patient is treated conservatively, where this patient not treated with reperfusion therapy. And 4 weeks after discharge, he undergo a test where it found that silent effort induced ST segment depression. So this greatly increased the risk of sudden cardiac death. And in June, so this patient coronary angiography revealed the LVEF is normal, means there is no heart failure or any dysfunction in the heart. So, but there is occlusion and stenosis where it can become the point that we have to take care after this. So why? It's because we're afraid that ischemic heart disease will occur in these patients. And in March, patient started to complain with the retrosternal constriction where he experienced dyspnea, and SOB may indicate the left or right side heart failure. So here we start to pay attention and confirm. The second coronary angiography is being prescribed to the patient, where it result reveal progression of arteriosclerosis and it's worsened in the stenosis and occlusion. So here, CABG is not given and not considered in this patient because it's reported higher surgical risk. And also, there will be high risk of complication because patient age is 83, is greater than 80. And so it's continue with palliative percutaneous coronary interventions. And starting from here, the pre-discharge echocardiogram documented a reduce of the LVEF where it's lower than 40. So this indicates high risk of heart failure. And now we will review the medicines that's given to the patient. Is aspirin. Low dose aspirin is given and this aims to reduce the risk of recurrent MI since patient first have experienced AMI. So here atorvastatin is given, but it's 20 mg, and we consider to use high intensity statin, and this aim to reduce the LDL cholesterol in the patient. So it's also given the oral lowering agent and also amlodipine and salmeterol-fluticasone, which is for lowering the blood glucose, treatment for hypertension with diabetes, and also is for the COPD treatment. So it's recommended that the dose of aspirin is changed from 100 mg OD to 75 mg OD because it's recommended as in a guideline. And also we have to monitor the symptoms of bleeding and also the plasma level. And then atorvastatin, if for high intensity treatment, it suggests that atorvastatin used between the range of 40 mg until 80 mg OD. So we have to monitor for its efficacy and toxicity as shown above. So since the patient is still smoking and is an active smoker, then we will suggest that patient undergo smoking cessation program. Combination of metformin and glucoside effectively reduce HbA1c in Indian patient with type 2 diabetes mellitus shown in the study, and also atenolol reduce mortality in patient with COPD and coexisting CAD. So next is the CCB. Sorry. CCB is the first line therapy for patients with diabetes without albuminuria and CAD. So here CCB have advantage over diuretics where it reduces the mean BP in patient aged greater than 50 years, where in this case patient is an 83 years old man. Lastly, for treatment of COPD, this article report by Liu and colleagues shows that improvement of lung function was significantly greater after treatment in an experimental group than in a control group where it's used the salmeterol and fluticasone. So in June 2009, patient undergo coronary angiography and the LVEF is normal, but there is occlusion and stenosis in the patient. So the medication same as previous, and addition of pyrindopyl and also oral isosorbate mononitrate in patients, while there is increment of dose metformin and change of medication from atenolol to bisoprolol. So the addition of pyrindopyl is used combination with the amlodipine to reduce cardiovascular event in subject with hypertension, and isosorbate mononitrate is used to prevent angina caused by coronary artery disease where there is stenosis in the patient now. And also metformin, we increased dose, which seems that maximum benefits were observed at upper limits of the recommended daily dosage reported by Garber studies. Lastly, the change of beta blocker is rare due to the benefits of bisoprolol over atenolol. So in December 2012, the issue of patient complaining worsening dyspnea and also angina need to be treated, and also there is a sign of worsening heart failure where patients have undergo bilateral edema, and this indicates left side heart failure. And also there is reduced in the LVEF smaller than 20%, which is a very severe heart failure in patient. So the pyrindopyl dose was increased, and also there is reduction of metformin dose, and the furosemide is added, and amlodipine may cause side effect where we will consider other recommendation after this. So just now we mentioned that the metformin dose is reduced back to the previous, which is 500 mg. So this is based on an article reported by Zimmerman and colleagues, where lengthened glycemic control with newer therapeutics agent has shown to reduce significantly mortality and morbidity, and also the risk of developing heart failure in diabetic patients with proven cardiovascular disease. Hence, we suggest that additions of empagliflozin for the treatment of diabetes mellitus in patients as well as the heart failure. So here we'll monitor the FBG, HbA1c, whether it's reduced until our target, and also assess the signs and symptoms of hypertension, ketoacidosis, acute kidney disease, and acute kidney injury, and so on. So next, furosemide is added in this case because its symptoms and sign of the heart failure with edema. So furosemide is the loop diuretic where it can help to remove these edema conditions, and also thiazide with potassium sparing agents may prefer in elderly population. So we suggest that the dose of furosemide reduced to 40 mg/OD, and also recommend that thiazide could be used as alternative. And here amlodipine is a CCB. It suggests that low dose combination therapy is preferred, where it's combined with the ACE inhibitors or ARBs to the calcium channel blockers. This can significantly reduce the vasodilated edema, and while additions to diuretics. So since we prescribe amlodipine in low dose, and also we use with ACE inhibitor and diuretic, it should be no problem. But if symptoms of edema occurs in patients because it's the side effect of amlodipine, then we suggest to change amlodipine to extended release nifedipine because nifedipine originally is short acting. In March 2013, there are changes of drug in patient, changes of medication because there is better tolerability and outcome data with nebivolol than in bisoprolol in elderly patients with heart failure. And while for perindopril, there's no indication for treatment of heart failure. But there is a case article reported here mentioned that perindopril significantly improved cardiac sympathetic nerve activity where compared to enalapril. In September of the same year, there is addition of several medication, where these are the goals of therapy. So addition of ivabradine in this case is because there is benefits shown in this trial. And also, the trimetazidine was reported that is more effective than isosorbate dinitrate in treatment of angina pectoris. So next is metolazone furosemide combination. It shows intensively used in the management of volume overload accompanying with the congestive heart failure reported in this study. And also additions of potassium carranoate is a potassium sparing diuretics where help to maintain normal range of potassium while it have the diuretic effect. So continue with the additions of clopidogrel, where this study mentions that it further reduced the risk of MACCE, MI, stroke, and BARC major bleeding compared with the use of aspirin. And next is the increment dose of atorvastatin that I've stated before, which use of high intensity statin in this patient, where in the case it's additions increments of the dose in September, but we suggest that it's done earlier in this patient, where it's used for the secondary prevention of adverse cardiovascular event in this patient. In January 2014, there is no much changes in patient medication because patient no longer complain for angina nor dyspnea. And then patient missed his follow-up because he's feeling well. And in 2015, patients well asymptomatic no longer complain for any discomfort and have no limitation in daily activities. Unfortunately, in November 2015, patients were hit by mob and also he died in hospital due to trauma. So to conclude this, patient DM and also hypertension. Patient have occlusion and also stenosis, and it cannot be revealed, cannot be cleared very well. But patient is under control, drug medication control, and the DM is controlled for linear control, and the hypertension is also controlled. And also, don't forget that patient is diagnosed with heart failure after this. So patient with diabetes mellitus, hypertension, and also occlusions with heart failure need to control the glucose more lenient. And luckily that this patient can have extent of life and the duration of living, and the condition become well here, and it's not died due to the heart failure nor DM or acute MI. That's all for my presentation for case 2. Thank you for listening. Hi, now we continue with the case report 4B. It's about a 63-year-old Malay male with acute exacerbate COPD with pneumonia. Let's have a review on this case. So the yellow highlight is about the condition or some information, while the black underline bold information is what we need to pay attention after this. So patient AS, 63-year-old, Malay male, weight 65 kg, with vital signs BP, temperature normal, but the pulse was high, have tachypnea and fever for 3 days, cough, worsening SOB, shortness of breathing, and crepitations were heard, and hyperinflated uh, lungs, and also the breathing get worse during the physical activities. So in COPD, then AS, our patient, was diagnosed with COPD 8 years ago, and past 1 year, the SOB attacks become more frequent. So we consider why and what happened in this patient after this. And don't forget that he was ex-smokers, and now our patient is on MDI convenient. Uh, MDI is the metered dose inhaler, and no other medical conditions. So patient present in the hospital and was ordered the test, where the laboratory finding have shown that the urea and creatinine level of patient is high, and creatinine clearance is calculated as shown here, where it's 40.43 milliliter per minute, where it indicates that the patient has moderate renal impairment. So we have to take into consider if we give a drug that needs other dose adjustment. And other reasons for high creatinine in the serum and also low creatinine clearance can be due to high the pressure of carbon dioxide and also lacking oxygen. This medical condition known as hypercapnia, and where the kidney cell they need high oxygen demand, and when we have low oxygens, then this cell cannot get enough oxygens and cause the uh, glomerular filtration to become low, and thus it will cause low creatinine clearance in the patient. And also, besides, here, inflammation can contribute to kidney damage in patient too, and also the age of patients will increase the risk of renal disease in COPD patient. So we have to take all these factors and also conditions into account, and we will see later on what happened and what is the diagnosis of this patient. And hepatic function of this patient was normal, supported by normal level of this chemical constitution in the blood. So here, patients have normal coagulation profile, which indicates that there is no problem in the blood coagulation, but white blood cells seems to be high, and also this may indicate they have infection or inflammation in the patient. And next is the low hemoglobin and hematocrit can cause tiredness, weakness, and shortness of breathing. Next is the pH level. It shows fluctuations, which means that sometimes it's above higher than the normal and sometimes it's lower than the normal. And pH value have something to do with the acidic and also alkaline level, which affect by the carbon dioxide, oxygen, and HCO3 content in the blood. So pneumonia is observed at increased rate in COPD patient, and we will take any risk here as account. So based on the laboratory finding, various examinations on this patient, and we also consider that signs and symptoms that we have mentioned just now, we conclude that this patient experienced acute exacerbations COPD precipitated by pneumonia, and patient was able to orient to time, place, and with GCS 15/15, which suggests that no consciousness impairment and no brain functions or any injuries in the brains of these patients. And this AECOPD can be caused by various reasons, maybe due to the bacteria, virus, or pollutants where it needs further laboratory tests as the confirmation. Let's see how this patient was treated. In the ward, patient was given unacin, hydrocortisone, and also the ranitidine. So unacin is an antibiotic where it has a combination of sulbactam and ampicillin. And both of these antibiotics have different mechanism of actions where it helps to act differently and more effective in treatment of bacterial infections. And injection was given for the treatment of pneumonia, and because we suggest that in these conditions, patients have pneumonia caused by bacteria. And next, hydrocortisone was given to reduce lung inflammation and also prevent respiratory failure in the patient. And it seems to improve the lung function and shorten the length of hospital stay for the patient. And next, here, since incidence of peptic ulcer and GERD more common in patients with COPD, so we will consider give H2 receptor blockers, which is the ranitidine, to the patients for the treatment of gastrointestinal disorder in COPD patients. Now let's see the first pharmaceutical care issue for this patient is where lacking oxygen therapy because this patient was diagnosed with acute exacerbation COPD, but there is no oxygen therapy and also not mentioned about the oxygen saturation in this patient, but we always need to maintain that the saturation of oxygen is greater than 90%, so we consider giving oxygen therapy for the patient also. And this aims to reduce the pressure of carbon dioxide and to maintain PO2 in between 55 to 60 millimeter mercury. So these are some of the literature review, and we recommend that we provide oxygen therapy or non-invasive ventilation to this patient, and we have to control the oxygen saturations, and we should monitor the level and check for arterial blood gases and also the oxygen concentration in this patient. The second PCI is lack of nebulized bronchodilators because we can notice that the patient was not given any bronchodilators even though it's COPD, and in addition, it's acute exacerbation condition. So this aims to relieve the shortness of breathing and any other symptoms cause difficulties breathing in the patients. So we recommend that we add SABA and also AAC in the patient. So give salbutamol in this dose, and also ipratropium can also be given and added for the therapy of salbutamol. So we have to monitor whether the condition has improved and the frequency is reduced and other signs in these patients. And this can be given in a nebulized form or in metered dose inhaler and via spacer device. And number 3, we will consider change dose and frequency in some medication, which is for the hydrocortisone. So this aims to reduce the risk of exacerbation and improve quality of life in patients, as well as the use of corticosteroids can improve the response to bronchodilators. So here is the literature review where it's mentioned in this report by Singh and colleagues. It's mentioned that short course of systemic corticosteroids in acute exacerbation of COPD have been shown improve spirometric outcome and clinical outcomes. So we will use it and change to optimum dose and frequency. So here we recommend to change the dose and frequency of IV hydrocortisone to 200 mg 6 hourly, which means 4 times per day, and to monitor whether it's improvement in condition as well as the FEV peak flow, and also monitor for toxicity includes is there any side effects occurs in this patient. And number 4, we will consider give some advice to the patient and have some patient counseling session with the patients and add some required dietary change or other things that's required for these patients. So the goal is to raise the HB level first. This one, we can consider adding iron supplements and also advise patients to take more food with high iron content. And also increase vitamin B complex and vitamin C intake, where this vitamin can help in the absorption of iron. And hopefully it will ultimately affect and also improve these conditions and can increase the level of hemoglobin in patient. And also next, the second one is to raise the protein level, which we advise patient to eat meal with protein. And also because patient have low potassium level, and we will consider to improve the level by advise patient to take more potassium rich foods, for example like leafy greens and banana and the others. So in this condition, we can conclude that this patient have acute exacerbation COPD, where we know that the oxygen concentration is very important to maintain in optimal level, because lack of oxygen is very dangerous for the brain function and also our kidney function, our heart function. So we have to always ensure that there is optimum oxygen level by we can give the oxygen therapy, and also we can consider bronchodilator in the patient, and any other level imbalance or abnormal level in the blood, then we have to consider so that the patient is treated well and can have free of any side effect and any sign and symptoms of the disease. So this reference I have used in both of these case reports. Thanks for listening. That's all for my presentation. Bye.